Please go ahead.
Welcome to HireRight's webinar, What You Need to Know About Oral Fluid Testing. We are glad that you could join us today. I'm Lucy Murray, Senior Account Analyst for our Drug and Health Screening business here at HireRight, and I will be your host for this event. HireRight prepared this presentation for informational purposes only and is not intended to be substituted for legal advice. If you have any legal questions, please direct them to your legal counsel. Before we begin, I want to cover a few housekeeping items. We will not be providing copies of today's slides. However, we will be sending out an email tomorrow with a link to the recording and your HRCI and SHRM credit information. If you are experiencing any audio or visual issues during this session, please refresh the browser window by clicking F5 on your keyboard or let us know through the Q&A icon at the bottom of your screen. After the presentation, we would appreciate getting your feedback. Please take our short survey. Let us know if this session was valuable and if you have any ideas for future topics. HireRight speaker for today is Dr. Simo, HireRight Chief Medical Officer and Managing Director of Transportation. You can review his bio in the speaker folder. Dr. Simo, I'd like to turn it over to you.
Hey, thank you very much, Lucy. And for all the people on the phone here, I'm giving a round of applause for Lucy. Lucy stepped in at the last minute because our normal moderator, Katie, who's our Director of Product, had some issues and couldn't be on today. So I really want to thank Lucy for kicking this off because I certainly wouldn't have done as good a job as she had. So from an agenda perspective, we are going to talk about oral fluid. So there's a lot of things happening in the oral fluid world right now. Within the past few weeks, DOT has approved oral fluid as a drug testing specimen. So we will talk about what that looks like from a DOT perspective and those considerations. Prior to doing that, I am just going to review what is oral fluid. What's the utility of it? How can it be implemented? Some just basic nuts and bolts things about oral fluid as a specimen. The next, I am going to compare it to how it looks against other specimens. So if you attend my, annual, what I say tongue-in-cheek is the State of the Union address for drug testing, many of this data you've already seen. Now, I am going to talk about point-of-collection oral fluid testing. Point-of-collection oral fluid testing right now has gotten a lot of inertia within the marketplace. So I am going to talk about how laboratory-based oral fluid compares to on-site oral fluid or point-of-collection oral fluid testing. I am going to touch on regulations around oral fluid testing, as well as to give you a more thorough DOT update, and really round this off with talking about some best practices on how to implement an oral fluid testing program. And I apologize, my system is now reconnecting virtually. So what is oral fluid and how does it work? And I apologize for the, snafu there. So from that perspective, oral fluid, is really a mixture of things present in the oral fluid cavity. One of the major components of oral fluid is just saliva itself. But that's not the only component that's contained in oral fluid. There's also, gingival cervicular fluid, or better called cellular debris. So just as your cells slough off in your mouth, there's the debris from that kind of slough off the cells from your cheek and gums. And the last thing is the oral mucosa transudate, which is really, things that enter your oral fluid, your mouth by crossing, your cheeks and gums, to go from the blood into the oral fluid. Therefore, oral fluid is what's called a serum analog, which means oral fluid fluid substantially has the same stuff as what's in your blood, or from a so to speak chemistry perspective. So if you do cocaine, cocaine metabolite is in your bloodstream. That cocaine metabolite in your bloodstream enters your oral fluid space, and it is part of that oral fluid matrix. So really, the oral fluid, from a testing perspective, one of its strengths is it has an outstanding relationship to use. I.e., it's essentially what's appearing in your blood for nearly everything other than THC. So, and oral fluid is a, observed collection. No one can bring in their significant other's oral fluid as their own, because if they, so to speak, did that, had their significant other, spit in their mouth in the morning, well, within about 10 minutes, that oral fluid that was their significant other's now has been replaced by their own. So you really can't subvert the specimen in that way. Furthermore, if they had their significant other's, oral fluid in their pocket, well, since it's observed collection, it's not like they can easily put the collection device in that tube and so to speak, substitute the specimen in that way. So again, not easily subverted, basically due to it being an observed collection. As I talked about just prior, the big difference in oral fluid than the other drugs is THC. Because it's not really looking for THC in the bloodstream. THC in the bloodstream lasts for just very short periods of time, before it's essentially migrates into fatty tissues, particularly the brain, where delta-9 THC has its predominant effects from an impairment perspective. But oral fluid does look for active THC that has been embedded within the, oral fluid, mucosa, cellular debris and such. So, and it does look for active delta-9 THC, which is, very pertinent, due to, rules being propagated in both California and Washington, which starts on January 1st, 2024, where if you're going to test for THC, you have to test for the active, psychoactive component of THC, and oral fluid actually does that. Another strength is oral fluid can easily be collected, by, novice, so to speak, novice collectors, non-medical personnel, without a big icky factor. Watching someone, provide an oral fluid specimen is about the same as watching someone brush their teeth. It's fundamentally no different. And once again, there are point-of-collection tests available for oral fluid. One of its major weaknesses right now, which may be addressed with DOT approving oral fluid, is when we look at our greater than 20,000 collection site network, there's very few collection sites overall that collect oral fluid. One of the challenges in terms of oral fluid collection is there's a variety of different collection devices out there, and those collection devices are tied to the laboratory. So a laboratory such as Clinical Reference Laboratory uses the Intercept collection device and has its reagents set up to extract from that device and then test, whereas a laboratory network like LabCorp uses a device called Quantisol. So collection sites tend not to carry a bunch of devices. Furthermore, the devices to collect oral fluid actually have a cost to them, whereas laboratories will give you urine collection cups at no cost. So therefore, the collection site network is small. That may change with DOT. And it also has the smallest detection window. So when you look at hair certainly has a detection window of at least 30 days out to 90 days. Urine, has a detection window, of about a week, unless you're talking about methamphetamine, cocaine, and amphetamine. The collection window there is a couple days, and that collection window is actually the same as oral fluid. So oral fluid really doesn't have a much smaller detection window when you look at the drugs that are easily dissolvable in water, such as cocaine and methamphetamine. but it does have a markedly shorter window for THC detection. So THC, is detected by, when you smoke, marijuana or smoke THC or use a THC gummy bear. THC gets stuck on your buccal mucosa, and the oral fluid test, so to speak, detects that. The window of detection, we'll talk about later, but it's far narrower. It's less than 24 hours in oral fluid from time of use. Whereas in urine, if you're a very sporadic user, that detection window is a few days. If you're a chronic daily smoker or a chronic obese daily smoker, when you look at the best available studies, your detection window is only about a week, maybe 10 days. It's not the 30 and 90 days that you see all over the internet, but it's still, 7 days is much longer than less than a day. So it does have a disadvantage detecting, marijuana outside of that 1 day period. Now, from a life cycle of a drug screen, if you're doing a laboratory-based test, there's really no difference whether it's oral fluid, urine, or hair. There's a collection event that then gets to a ground courier that brings it to an air courier that brings it to the laboratory. So the life cycle of drug screen isn't any different. From a collection process, it is a bit different because the primary role here, of the chain of custody process is to basically establish that, specimen 123 collected on John Donor is John Donor's specimen. And the collector is really the person in oral fluid testing that just watches the collection process. They're not actively swabbing the person's mouth. If the person swabs their mouth themselves, the collector's there just witnessing that John Donor does it in an appropriate way and that John isn't dipping it into, a water bottle sitting in front of him or doing something else to try to subvert the test. And that observer is there to assure that there's no testing. And then the chain of custody is there to say, I, John Donor, have submitted this specimen, and this is my specimen sealed in my presence. And it's also the collector saying, hi, I'm, Joe Collector. And, I was the person that witnessed John do this, and this is John's specimen, and I was there the whole time. That's really the collection process, which is fundamentally the same as urine and hair. However, it's much more passive than urine and hair because in hair testing, someone is clipping a person's hair and is actually interacting with the person in that way. Or urine, a person is going into a restroom by his or herself, and they come out of the restroom with the urine sample, and then the collector has to do a variety of validity checks on the urine specimen to as a, so to speak, measure to make sure the person didn't subvert the specimen. And again, you've heard me talk before that urine drug screens are very easy to study for, whereas oral fluid, being a witness observed collection, you really can't study for it. This is just another slide of the collection process. This is showing the Intercept, one of the Intercept devices. I'm not putting this on there endorsing any given product. They just had some nice slides saying you kind of stick it in your mouth and swab it around. There's a volume indicator. Once that volume indicator indicates that the swab has been soaked with oral fluid, it then goes into a preservative. It's then capped and sealed. It's really that easy of a collection process. So again, from a collection perspective, the advantages are it is an observed collection. It essentially eliminates donor subversion from the process. That's good. There's no handling of urine. Again, most people don't like to handle someone else's urine, or not even their own urine, so to speak. So from that perspective, there's no handling of urine. The donor collects the specimen themselves, and again, the collector's just there, managing the chain of custody process. Currently, it's very easy to become a certified collector. The different devices have different training videos that you watch that you can then download a certificate saying that you're now a certified oral fluid collector that you went through the training for oral fluid collection, and those videos are all less than 10 minutes long. Next advantage is there's no such thing as a shy bladder. If someone doesn't go to the collection site or start a collection event and go, well, I just don't feel like urinating right now, or I can't urinate, I just urinated before they told me to come in. So there's no waiting around for the person to have the urge to empty their bladder, that you can essentially do this upon identification. I'm sure as this rolls out that someone will come up with a dry mouth, but again, in the decades that I've supported oral fluid, I have not seen that arise as of yet. And then, the collection site, the collection area doesn't require plumbing, i.e., if you're in an office space that only has, one bathroom area, you don't have to occupy the bathroom area and keep other people from coming into the bathroom because you're doing oral fluid collections. You can just select another area, in your office or warehouse, factory to do the test or collect the tests. There are some known pitfalls. Company needs to feel comfortable to collect the specimen. So, if you decide, no, we want to use a collection site network, the cost of your drug testing program will probably go up around 50%. And the reason I say that is, oral fluid testing itself is a bit more complicated from a laboratory perspective, and therefore the cost of the actual oral fluid test is about 50% more than a urine test. You also do have, the collection supplies that cost a few dollars, but there still is a static cost of that. And then you're also paying a collection site to collect the specimen. If you decide to collect it yourself, in all likelihood, your drug screening program will go down in cost because the collection site is a big piece of the overall bill of a urine or hair collection. The next known pitfalls is, I haven't read the complete release from DOT yet, but DOT will likely require a more rigorous proctor training to be a collector. And from a DOT perspective, you can train collectors today to be, to collect urine samples. There's no prohibition to that. But immediate supervisors and coworkers within the same testing or same random pool should not be the collector. And the only way a supervisor could act as a collector from a DOT perspective, if there is no other means to get that test done. So again, those will likely be part of the rules for when they release the modified Part 40. That will be the same in oral fluid as in urine. And again, even though I said you don't need a so to speak, bathroom facility to do the collection, you do need to have a clean collection area. So you can't just do it, in an area that has, other specimens laying around, or an area which is not considered, clean, where there could be cross-contamination with something. So again, when you're doing these things, within, a warehouse, you want to bring it to an office and have that office neat and tidy, and really a one-to-one relationship between the collector and the donor. So the transit of the specimen, there's still, if it's going to a laboratory, there's all of the problems that relates in sending a specimen to the laboratory. Things get lost in transit. Specimens get destroyed in transit. Specimens leak in transit. None of these things are any different whether it's oral fluid or urine. One of the big differences between the two are the impact of a delayed specimen. So if you collect a urine specimen today on Sally donor, and Joe collector forgot to put it in the courier bin, and it sits at a collection site for 7 days, there is a good chance that Sally's specimen is going to have an abnormal pH, because as a urine specimen ages, that urine specimen's acidity level goes down. And one of the so to speak, validity tests that are done on urine is to make sure it has a normal, pH, a normal acidity level. So, Sally didn't do anything wrong. Joe's the one that forgot to put it in the courier bin, and now Sally has an invalid result. So there are rules, with how an MRO handles that, but that's just noise in your program that oral fluid doesn't have. Oral fluid is placed in a buffer. It doesn't require refrigeration or anything else, and that buffer is good for at least 2 weeks. It's really a mark that from an FDA approval process that they showed that it stabilizes the specimen for at least 14 days, and it may actually stabilize the specimen for much, much longer, but they just didn't go out to prove that. So oral fluid does have the advantage that if you have some sort of delay in the transit of that specimen, whether it's at the collection site or with the courier network, it doesn't impact the validity of that specimen where it can with urine. So testing, again, the laboratory testing perspective is really no different. They accession the specimen. They look for fatal flaws in it, like the collector, did something wrong or didn't handle the paperwork right or forgot to put the specimen in the bag. And if those things happen, the laboratory rejects that specimen from testing. And then the next initial testing part is the real difference. There's really two differences. The first one is urine, once it reaches the lab, can be sent to testing immediately. Oral fluid reaches the lab. Oral fluid needs to be extracted from the buffer, extracted from the other liquid that was in that bottle, and then it can go into testing. Hence, one of the reasons the test from a laboratory perspective is more expensive. The specimen validity tests are different as well. Urine looks for a variety of things like, urine, the acidity level, the pH, the, specific gravity, the creatinine level, where oral fluid is looking for one parameter, and humans have immunoglobulin in their oral fluid, and what the lab is assuring is that there's a normal immunoglobulin level in the oral fluid. And then the next big difference is the immunoassay test. Not that the immunoassay test is any different. It's essentially using the same technology. However, the testing cutoffs for oral fluid are much different and lower than urine. So the immunoassay tests have a different, so to speak, concentration level than urine do, and they are lower. And the lower you go, the more, so to speak, difficult or more expensive that immunoassay tests can be, and therefore there's another reason that the test from a laboratory perspective is higher. Confirmatory testing, again, it's using the same technology no matter what the specimen is, using a chromatography and a mass spectrometry. So they're doing two independent confirmatory tests on it. So that meets all the state rules that say you have to have two independent tests to prove that the specimen is possible. That's happening in the normal course of business, whether it's urine, oral fluid, or hair. And from that perspective, the big difference here is, again, just the confirmatory level. In urine, the confirmatory level for, delta-9 THC metabolite is 15 nanograms per milliliter. In oral fluid, the confirmatory cutoff for, delta-9 THC is 2 nanograms per milliliter. So again, the machines go to a lower level. The laboratory can easily, toggle their machines, or can toggle their machines, I shouldn't say easily, but can toggle their machines to detect at those levels, so they're able to do it. But again, the lower the cutoffs, potentially the more expensive the test. So how does oral fluid compare to the other specimens? So again, laboratory testing rates, Quest Diagnostics, is gracious enough every year to post their laboratory positive rates for the year before. So in 2022, they provided us their 2021 data. And you can see that, federally mandated urine had the lowest laboratory positive rate, whereas hair testing had the highest. And you can see the general workforce was 5.6%, and their oral fluid positive rate was 7.3%. And then the bar in red is the National Survey of Drug Use and Health that was published in January 2023. And what they do is survey a bunch of people, and people say, I used a given drug, and part of that menu of drug is THC, is marijuana. And, 13.5% of the U.S. population admitted to using an illicit drug within the past 30 days. So that's the data set. And I look at the data set for people 26 years of age and older, and that survey has multiple different data cuts that even looks at pediatric use. So this is really Quest data, over, a period with the National Survey of Drug Use and Health, And you can see that, year over year, people, are admitting to using more drugs, basically driven by marijuana, by THC. And you can see that, in 2018, 19, and 20, oral fluid lab positive rate was significantly the same as the hair rate. So now you have a window of detection of a couple days being the same as a window of detection up to 90 days. That's a pretty powerful statement in regards to the utility of oral fluid and how well it captures, drug use, because people that you're most concerned of are those chronic daily users. Well, you can see in 2021, the percentage in oral fluid dropped markedly to 7.3%. And in the ensuing slides, I'll kind of give you some information of why that is. So again, from a federally mandated urine perspective, so I just wanted to show you that, the majority of positives are caught pre-employment, with the highest positivity rate in the federal program being post-accident, as you would expect. And you can see that THC and cocaine and methamphetamine essentially represent the same amounts of positive tests at the lab. In fact, stimulants are a bit higher in 2021 from a Quest perspective. Where oral fluid, on the other hand, again, similar data that you see, just higher percentages from a test reason perspective, but you can see that the major analyte detected in oral fluid is THC, whereas, stimulants, methamphetamine, cocaine, amphetamine, ecstasy are far less. So one of the reasons that, is happening there is many specimens starting in 2021 in oral fluid started removing THC from their panel. And as they remove THC from the panel, they're removing the 84% of their positives. So when they drop that from their pre-employment drug testing pool, the overall positivity rate of the specimens going down, just because it's looking for a truncated panel where one of the top drug of abuse from an oral fluid perspective has been eliminated from that panel. So, lab positive rates are neat. What's more important to you are the urine positive rates. So from this perspective, this is HireRight data over a 5-year run. And you can see that, the urine MRO verified positive rate, so this is both non-regulated urine as well as regulated specimens, sits in just over the 2% range. Whereas oral fluid, was at 7.5% in 2018 and was the highest positive rate specimen. And you saw that it, went down kind of through the pandemic and then had a rebound in 2022 going up to nearly 6%. And then you can see hair has been fairly stable. 2022 did see a 3-point increase. So let's look at that a little bit further. Oral fluid positive rate, when I look at panel comparisons, currently 31% of our oral fluid tests do not contain THC. The MRO verified positive rate of that 31% was 4.5%, whereas the other 69% of tests had a positive rate of 7.9%. So really 4.5% to 8%. So you can see that This 4.5% is certainly higher than what you see in urine, but when you add THC to the mix, a much higher rate. And just to show you HireRight positive data in a more granular manner, non-regulated urine was at 2.5% MRO verified positive rate. DOT urine was at 1.2%. Oral fluid without THC, 4.5%. Oral fluid with THC, 8%. And hair was 9.4%. So is there a difference between lab-based versus oral fluid from a point of, so that's point of collection testing. So point of collection testing really takes the laboratory immunoassay process and puts it in the hands of the collector. So the specimen is given, the collector then is able to read the initial test. And in some cases, there is actually the manufacturers of the point of collection devices actually have a cell phone-based app where a digital chain of custody can be created. And then instead of a collector reading the device, the app reads the device, and the app says, yep, this one was negative, and actually creates a result. Or, oh, this one needs to be sent to the laboratory. It's non-negative, and then it has to be sealed and sent to the lab. But the initial test happens on site, and if the initial test is non-negative, a laboratory confirmation test is needed, because immunoassay tests are very sensitive but not specific, and therefore, you get false positives from those immunoassay tests. If you use enough Sudafed, those point of collection devices say you're positive for methamphetamine. When it goes to the lab for confirmatory testing, it fails to confirm. It's a negative test, but it's because the immunoassay test can be tricked. Whereas the laboratory confirmation tests with the chromatography and mass spectrometry are exquisitely sensitive and specific. Therefore, you don't get false, negatives or false positives. Excuse me. So you do need that confirmation test in place. So the life cycle of the point of collection test is pretty easy here. You have a collection event, it's read, and if it's negative, you get an immediate result that says Sally Smith is negative, and then you can proceed to the next phase. So you have a conditional offer of employment, Sally has her negative test, all of a sudden you can send, you can initiate a background screening package, send Sally to a kiosk within your factory, and Sally can complete all of her consents so a background screen can be done, all without Sally leaving the building. However, the collection event happens, it's read, and the line really should be going from red to ground courier. If it's red and it shows, hey, this test is non-negative for whatever, it then goes to a ground courier. That ground courier sends it to an air courier, which sends it to a laboratory, and then the laboratory tests it, and then you have a laboratory confirmed result with an MRO process in place to give the person complete fair play. So, the big difference between laboratory-based oral fluid and point of collection oral fluid is really THC. So I'll start with the right-hand side of the slide first. When you start looking at drugs like cocaine, amphetamine, methamphetamine, most of the opioids, most of the benzodiazepines, and a large amount of barbiturates, those are all what's called water-soluble drugs, which means they're easily dissolved in water. Well, those things, throughout their, metabolism, essentially get eliminated in urine very rapidly. So the detection window of, the stimulants in particular, the first three drugs on the right-hand side of the sheet, really only have a detection window in urine of a few days. Well, that's really the same with oral fluid. So oral fluid and these other drugs have about the same detection window. Where it differs from a science perspective is delta-9 THC, as I alluded to before. There's a substantial difference between it. The point of collection devices, laboratory point of collection devices, screen at 4 nanograms per milliliter of neat oral fluid, and confirm at 2 nanograms per milliliter of neat oral fluid. Some of the labs report different levels because they're using a dilution factor of the buffer, but that's essentially what we're testing at. Where point of collection devices, the ones with the lowest levels go down to about 10 nanograms per milliliter. Others of them are higher than that. So the window of detection in laboratory-based oral fluid is less than 24 hours. The window of detection using point of collection oral fluid is more in the range of 4 to 6 hours, more in that range, and therefore knowing that THC is intoxicating for a period of about 4 to 6 hours, the point of collection devices are detecting that use just prior to the collection event. And here's some data slides to support that. So on the left-hand portion of the slide are, volunteers giving unit doses of THC. So one group got a 50 milligram dose, another got a 25 milligram dose, another got a 10. From that perspective, you see that you use it, your oral fluid immediately goes up and essentially spikes in about 15 to 20 minutes. And depending upon how much you use is how high the spike goes. But then you can see over the next hour, that essentially starts approaching the baseline, no matter if it was 50 or 10. So it rapidly goes down. Whereas if you are a chronic user in the black line or an occasional user in the gray line, and disregard the CBD, this is part of another type study, well, you can see that the oral fluid of the chronic user is sitting out here at a level. Well, then they all of a sudden stop using and then use. So you can see at negative 19 days, they were fairly high. They kind of have them, stop using within this period of time, and then they collect, and you can see it goes up, and it's 19 hours, You can see that it goes up. But again, at the screening of 4 level, you can see that THC essentially is out of that chronic daily user in about 21 hours. So that's why I'm saying the detection window is less than a day. And knowing that the impairment window of THC after single use from an occupational health perspective or occupational safety perspective is well over 24 hours. That's why I report that I'm happy to say that oral fluid can be used as a marker of impairment, and any employment action being taken is based upon that impairment. So are there any regulations around oral fluid? Well, there certainly is. The big state that you need to know is Vermont. So Vermont doesn't allow oral fluid testing, doesn't allow hair testing for non-DOT positions. When DOT, now that DOT's approved it, they will have to allow oral fluid for DOT positions, and maybe that will change the drug-free workplace stance of Vermont. But right now, Vermont does not allow any oral fluid testing. There are then, 5 states here that prohibit, and this isn't particular to oral fluid, but this is just in particular to point of collection testing. So whether it's, oral fluid or urine, there's the 5 states here, Kansas, Minnesota, Nevada, New York, and of course, Vermont again. There's the 5 states here that say you can't do point of collection testing, period. There's rules in place that make it, either you can't do it or you have to be, approved as a laboratory the same way as one of the reference laboratories do. And then there's another group of states here, 6 states that, they do restrict the use. Most of these states are restrictive in regards to you can't do it unless it's pre-employment. So you can't do it on a current employee, like, North Carolina, like Georgia. You have states like Alabama, which basically say, yeah, you can do it, but if you can't use it to deny workman comp. So to me, fundamentally makes it very similar to just doing it for pre-employment. And then there is Oregon that, in order to do it as an employer, you do have to register with the state, pay an annual fee, a nominal annual fee of $50. You can do it, but there are, those restrictions that you just can't launch a program and do it without abiding by those rules. So what's the status for DOT? Well, we know in September 2019, after about 8 years, HHS, Human Health Services, said oral fluid can be a sample for the federal government testing program. Well, DOT got that, released the notice of proposed rulemaking, and just this month has released that DOT approves oral fluid as a specimen. You can start using oral fluid as of June 1st, 2023. Well, right now you can't. Even at June 1st, 2023, because there is no lab or collection device that has been approved or certified by Department of Human Health Services for testing. These certifications are underway. In terms of talking to my industry contacts, we're looking at least 6 months to a year before this will really be available from a testing perspective. So what are some other points for DOT? There are some nuances that within the rule that DOT propagated. Number one, you, the employer, gets to decide which specimen is done. So the donor doesn't get to go in, or the collection site go in and say, hey, we've run out of oral fluid devices, we're doing urine today. Or the donor can't go in and say, I just want oral fluid because I heard a webinar that it has the lowest detection window for THC. So you, as the employer, get to decide what specimen is. DOT did say that they like oral fluid and is the preferred specimen for any observed collection. Who wants to watch someone urinate, and you need to have a same-sex person watch them urinate. And within the rule is further, it's the only test that can be collected on someone who identifies as transgender. So, from that perspective, DOT in regards to, that issue, since the old rule was the collector needs to be of the person's, desired sex or chosen sex, now that takes it out of the game, that all it is you do an oral fluid collection. So any, U.S. DOT regulated clients on the call or participants on the call, you will need to create an oral fluid account, even if you intend not to use it as your primary specimen, to fulfill the program that if you do have a transgender employee that does need an observed collection, you need a mechanism to get that done. Still don't know exactly what collector training will entail and what that'll look like. There are industry unknowns of when will there be a sufficient collection site network. I know both LabCorp and Quest are setting up patient service centers to collect oral fluid in response to the DOT rule, as well as the regulatory changes happening in California and Washington. And will the cost of an oral fluid collection, which is very simple and straightforward, be as costly as a urine collection? Because today, it's just as costly, if not more costly, than a urine collection. So we'll have to see what the market bears in regards to oral fluid collection costs. And then there's your own industry roadblocks. What will your unions think? Are you willing to train your collectors to take advantage of the cost savings? And are there any policy considerations? So here's the best practices part. So the first thing is you have to identify, hey, what is going to be our usage scenario? Are we going to do, oral fluid as our sole drug-free workplace, specimen? Or are we going to do it, on just current employees? Or how are we going to use it? So again, you have to figure out the usage scenario. Number two, you have to figure out, well, what kind of panel do I want to have tested for? Originally, oral fluid was very much just a 5-panel test. Well, now oral fluid and those drug testing laboratories have multiple different panels available but there's not as many drugs available in oral fluid than there are in urine. So urine still has the broadest test menu, but the panels for oral fluid have increased. Next is hey, are we going to collect these specimens, or are we going to try to use a collection site network? And who in our company are going to be the collectors if we decide to, identify them and then get them trained? And then it's really a vendor selection. Are we going to use a company like HireRight to broker these tests on our behalf, or are we going to create a direct relationship with one of the drug testing labs? And the real use cases for oral fluid, in my mind, it's really the ideal specimen for random testing. And the reason I say that is, typically random tests, can occur at what I'll call a static facility. They're in a warehouse. They're at a distribution center. They're in a factory. They're at a trucking terminal. They're at a airport. So the people are there. And, you identify them and you can immediately test them, and there's no waiting for them to have to urinate. And in the trucking arena, that's really powerful because you have these things called hours of service, and going to get a drug screen counts against their hours of service. So if it takes them, the collection site, 3 hours to identify them as a donor and another 2 hours to get the specimen, that driver's, 5 hours of that driver's day of service has been used up. So that, that impacts their ability to move freight, whereas, to collect and be done within 10 minutes makes all, everybody, the donor, the trucking company, and guess what? Us consumers that are waiting for those goods to hit the market get there faster. So again, and it's great for for-cause testing, so those post-accidents are reasonable suspicion. Again, no dedicated bathroom, no shy bladder. There's finite collection period times that you should get these done, and it's easily collected. It's also great for what I call cattle call hiring events. And I say that cattle call hiring events is really those events where you're doing interviews, you're offering conditional, offers of employment right up front. Then you can all of a sudden do, an oral fluid test. You can send it to the laboratory, or you can do one of the point of collection tests if that meets your risk mitigation needs. And the nice thing about a point of collection test, you can all of a sudden go, wow, Jay, that was a negative test. And oh, by the way, go to that kiosk and fill out the link to do your background check. And before the person even leaves your facility, you can have the drug screen done and the background check in flight. It is not the ideal specimen for what I call dynamic hiring events, i.e. events where, hey, I interview, a Margaret over the telephone. I now give a conditional offer to Margaret. Now I'm initiating a drug screen. It's, the collection site network is small, and therefore it's hard for Margaret to go in. So urine has the widest network available, and using urine, or hair network's fairly widely available as well. That's a lot easier than at oral fluid at this time, although that may change now that DOT has approved it as a specimen. So, Lucy, I kind of, I've gotten the recommendations that I shouldn't speak to the end of the hour, and I appreciate those recommendations and have complied. So I kind of open up to you for kind of the final housekeeping stuff as well, go through any questions that may be there.
All right. We'd like to open it up for questions now. Please use the Q&A widget to submit your questions. The first one that we have, Dr. Simo, is why is oral fluid's positive rate greater than that of urine?
No, that's a great question. From an oral fluid positive rate being greater than that of urine, even though the detection windows in urine are quite higher, or quite longer, the detection rate in oral fluid's higher because it's a witness collection. As I've said on multiple webinars, you can study for a urine test. There's all sorts of ways to subvert it. You can, have, synthetic urine. You can have freeze-dried urine. You can bring someone else's urine in there. And since it's a non-observed collection, what you do in the bathroom by yourself, there's a lot of ways to subvert that test. So I believe the urine positivity rate is markedly truncated because 10 out of 10 people doing drugs know it, and many of them know how to beat the urine drug test. Whereas oral fluid, it's witnessed, it's right there. And again, I've actually talked to employers that have oral fluid testing program, and they say, the positive rate that I report is actually lower than what it is. And when I ask them why, they go, well, there's a certain percentage of when we say, hey, we're going to send you, we've got to do a drug screen. The person's like, oh, yeah, I'm ready to go. What collection site? They go, no, we're doing it here. And they break out the oral fluids, supplies. And the person immediately goes, oh, no, I got to leave right now and go do something. So they go, okay, well, we're rescinding our offer of employment. So, the positive rates that I'm reporting, according to many of our employers, are actually lower than what they're seeing at their facilities.
All right. Next question. Does a positive oral fluid test say the person was impaired at the time of collection?
No, and another good question. And what I'll say is it varies. When we look at every other specimen than THC, the impairment window of things like cocaine and methamphetamine, certainly using those does increase your risk for accidents and such. But, there isn't big studies showing how long does that occur. And with the detection window of a couple days from use, I can't with oral fluids say, well, they were currently under the effects of cocaine at the time of accident. I could say maybe cocaine had an impact on their ability, but I can't say they were definitively impaired from that substance. Well, delta-9 THC is really the difference here. With the detection windows that I showed being, less than 24 hours, even for that chronic user, and the known occupational safety risk that THC causes, I can say from an employment perspective, the person was impaired. So to a high degree of medical professional certainty, I can say that the person, did use within the day, within 24 hours prior to the collection of that test. And with the, impairment window being so broad that the person was occupationally impaired at the time of collection. But I can't say it for the other drugs in a panel. But great question. Next one, Lucy.
Is fentanyl detected in oral fluid?
So, if we go back a few years, I would say no. It's just not. But, due to the, fentanyl, so to speak, crisis that we're having, multiple of our lab partners do have oral fluid panels where fentanyl or fentanyl metabolite can be detected. So the answer to that is yes. A bigger question is should you test for fentanyl or not? I've been asked that at some of the trade associations I work with. The most recent was the American Trucking Association. And my opinion on that is, the overall positive rate in the employment sector for fentanyl is exceptionally low. Almost so close to zero, you can say it's zero. It's very close. HireRight did a deep dive of that in March. And of the specimens that had fentanyl in the package, which was about 1%, that 1% had a 0.03% positive rate, MRO verified positive rate for fentanyl. So it was 3 out of 10,000. So again, I believe most people whose drug addiction has gone to the point of needing to use fentanyl, they probably have opted out of employment. But again, that whether you test for it or not is all part of your risk mitigation program. Next question, Lucy.
How does oral testing affect the split sample test process?
No, certainly. So from there will be new devices out there, that will be approved for DOT, where essentially the two swabs will be together, kind of meshed together or put together, and the person will swab their mouth, and then they'll split the two pads away from each other, the two devices away from each other, sticking one in the A vial and one in the B vial. Currently, we do have clients that are doing kind of dual specimen collections, and what they're using are two devices, that they're swabbing in their mouth at the same time. So there are split tests available. Right now, it's really using two devices. DOT will want those two devices to be one device that'll be split once the device leaves the person's mouth. So that's right now in evolution, but there are mechanisms to get the split test done.
All right, this is the last question we have time for. If your question has not been answered today, we will get back to it via email. The final question will be, will we be able to use oral fluid for random and or reasonable suspicion post-accident testing?
From a DOT perspective, you'll be able to, from a non-regulated perspective, you can use it for all of those reasons except in Vermont. From a DOT perspective, you will be able to use them for all of those reasons. DOT had no prohibitions. It can be used for any test reason under DOT.
All right. Thank you, everyone, for attending today's presentation. Please take a minute to fill out the short survey. Your feedback is always appreciated. We'll be sending out an email tomorrow with a link to this recording and your HRCI and SHRM credit information. Have a great day.